Hi, it's Dr. Kripalu. I have personally reviewed and endorsed this video. Please watch carefully as it's a valuable resource for your practice.
All right, let's dive in. Today we're tackling something that pops up all the time on lab reports in the outpatient clinic. Hyponatremia, low sodium. My goal here is to give you a really clear, practical plan for the next time you see it. Let's get to it. So let's just start with this classic scenario, right? You get the lab results back and your patient's sodium is 129. It's not, crazy low, but it's definitely not normal. So the question is, do you just keep an eye on it? Or is this something you need to work up? What's the right move? The simple answer? At this level, it is absolutely time to act. A sodium level of 130 or less, that's our trigger point. That's the threshold where you really need to start a formal investigation. And why? Because this is the level where the risk of actual clinically meaningful problems starts to creep up. Okay, so here's our game plan. We're going to start with exactly when to kick off the workup. Then we'll walk through a super important 4-step algorithm. After that, we'll zoom in on how to diagnose the most common cause, which is SIADH, figure out what's triggering it, and then wrap up with the main principles for treating it in the clinic. So, why is 130 the magic number? Well, we now know from research that even mild chronic hyponatremia below this point is tied to some pretty serious stuff, a higher risk of falls, problems with gait, even cognitive issues. So it stops being just a number on a lab report and becomes a real potential threat to your patient's safety and quality of life. Now, the good news is that in the clinic, we're usually dealing with these chronic cases where the patient looks totally fine from a fluid standpoint, they're not dehydrated, they're not overloaded. But before we jump to any conclusions, our very first job is to confirm we're actually dealing with true hypotonic hyponatremia. And the way we do that is with this simple but incredibly powerful 4-step algorithm. This whole thing is based on physiology, it's logical, and here's the key. The order is not optional. You have to follow these steps in sequence to get to the right answer. And here they are, the 4 steps that will guide our entire workup. First, we check the serum osmolarity to see if it's true hyponatremia. Second, we do a clinical assessment of their volume status. Third, we check the urine osmolarity to see if the hormone ADH is playing a role. And fourth, we check the urine sodium to see what the kidney is up to. Okay, step 1, serum osmolality. Think of this as the main gatekeeper. It's pretty straightforward. If the osmolality is low, less than 275, congratulations, you've confirmed true hypotonic hyponatremia. You can proceed with the rest of the workup. But if it's normal or high, you're dealing with a different beast entirely, like pseudohyponatremia from high triglycerides, or maybe hypertonic hyponatremia from super high blood sugar. All right, on to step 2, assessing volume status. This is all about your clinical exam. Hands on the patient. Are they dehydrated? Do they have signs of fluid overload like edema? Or do they seem just right, what we call euvolemic? Because this euvolemic category, well, that's the most common one we see, and it's where SIADH lives. Steps 3 and 4 bring us to the urine labs, and they basically let us ask the body 2 really important questions. Question 1, is the urine concentrated? A urine osmolality over 100 tells us that antidiuretic hormone, or ADH, is active when it really shouldn't be. Question 2, is the kidney wasting salt? A urine sodium over 30 to 40 tells us, yep, it is. These 2 clues are huge. And now, we get to put all these clues from our algorithm together to nail down the diagnosis of SIADH, or the syndrome of inappropriate antidiuretic hormone. It's the most common cause of euvolemic hyponatremia, and our algorithm is designed to point right to it. So what does that diagnostic signature for SIADH actually look like? Well, you need a patient with low serum osmolality who is euvolemic on exam, has inappropriately concentrated urine, so that's a urine osmolality over 100 and a high urine sodium. But here's the critical part. Their kidney, thyroid, and adrenal function all have to be normal. It's truly a diagnosis of exclusion. I absolutely love this quote because it just gets right to the heart of it. You don't just guess at SIADH, you earn it. It perfectly captures the whole idea. You're proving that the hormone responsible for holding on to water is turned on when, physiologically speaking, every signal in the body should be telling it to be turned off. So once you've earned that diagnosis, your job isn't quite done. The next step is to put on your detective hat and find the underlying trigger. What's causing this inappropriate ADH secretion in the first place? Finding that is often the real key to treating it successfully. The first place you have to look for a culprit, especially in the outpatient world, is the medication list. You have to scrutinize it for drugs like SSRIs and other antidepressants, particularly in older patients. After you've done that, you can start thinking about other things like lung problems, CNS issues, or even an underlying cancer. Now, before you finalize that SIADH diagnosis, this part is non-negotiable. You have to rule out two critical mimics. First, adrenal insufficiency can look exactly like SIADH, so getting a morning cortisol is essential. And second, hypothyroidism can also cause a mild hyponatremia, so a TSH is a standard part of the workup. You just can't call it SIADH without checking these two. All right, so we have our diagnosis, we've looked for the cause, now let's talk about what to do. The guiding principles here are simple. Be slow, be safe, and be strategic. This is always a marathon, never a sprint. The foundation of treatment is really a three-step approach. Step one, and the most important, is to treat the underlying cause. If it's a medication, can you stop it or switch it? If that's not possible or it just doesn't work, then step two is fluid restriction, usually somewhere around 800 to 1200 mils a day. After that, we can start to consider adding salt tablets. So what's the deal with salt tablets? Well, they're definitely not a first-line therapy, but they can be a super useful tool for stubborn cases of SIADH. The way they work is actually pretty simple. By increasing the solute you take in, you basically force your kidneys to excrete more free water, along with that solute, which in turn helps bring the sodium up. Now, this is probably the single most important safety rule in this entire explainer. You have to correct the sodium slowly. You're aiming for a rise of no more than 8 to 10 points in any 24-hour period. If you go any faster, you risk osmotic demyelination syndrome, which is a truly devastating neurological injury. Slow and steady wins the race. Okay, let's lock in the key takeaways from all this. Takeaway number 1, do not ignore that mildly low sodium. A level of 130 or below is your clear signal to get a structured workup started. Takeaway number 2, that 4-step algorithm is your best friend. Follow it in order every single time. Serum osmolality, volume status, urine osmolality, and urine sodium. Don't skip steps. It's your roadmap to the right diagnosis. And our final takeaway, always be suspicious of medications like SSRIs as the cause and never, ever finalize a diagnosis of SIADH until you've officially ruled out both adrenal insufficiency and hypothyroidism. So I'll just leave you with this question to chew on. We know for a fact that chronic, seemingly asymptomatic hyponatremia is linked to about a 60% increase in the risk of falls. So when you think about it from a patient safety perspective, is there really any such thing as harmless hyponatremia? Thanks for watching.